Hi, everybody. Welcome to Navigating the Health System. It can be difficult sometimes navigating this health system. Even people in the system wonder how to navigate the health system when they need to do it on their own or for a family member. But what we've done is we've segmented this session into kind of two chunks. The first group of lovely ladies will be discussing insurance and how insurance companies can play a role in helping people navigate the health system and helping people to improve their health. And then the second half is going to be companies who are focused on helping patients navigate the health system. So they have service offerings and technologies that are focused on doing just that. So let me first kick off our section dedicated to member experiences. We've been running this track for a few years now, and I've been leading it because I am an insurance nerd. I know way more about insurance than I should, but I love it because insurance companies get a bad name. I think it's they have been on the bottom of the barrel for customer satisfaction, like competing with cable companies. They kind of like rotate. Sometimes cable companies are up, sometimes they're up. So when you're competing with Comcast for the bottom of the barrel, it's a tough life. But I know many people at insurance companies, and they are genuine good people who want to help patients improve their health and figure things out. And so, and they are in a position to make a tremendous impact because they can deliver solutions at scale. And so they have the opportunity to affect the lives of many. Now, with many of our insurance partners at MadPow, we are a strategic design consultancy. We focus on experience innovation, behavior change design, and executing the great ideas that we have with our clients. For our insurance clients, over 15 of them, we've been focusing on moving things in the direction of, instead of the if you build it, they will come mentality, we're going to make this great tool and it's going to fix everything and people are going to come and use it. Well, people can't come and use the amazing tool if they don't know about it, right? If it doesn't integrate into their normal lives and their workflows and the way they think about things, right? So we think about how do we, instead of expecting members and patients to come to us and do the work, how can we leverage technology in our internal systems and processes to do the work for them, to reach out to them proactively? I often like to pose the question with our clients, what if you didn't have a website? What would happen? And what I mean by that is, let's not, blow up your website. You need that, but how do you get the right message to the right person at the right time? Through outbound voice, through text, through email, and when they call into the call center, right? When they're at the doctor's office, how do you interact with them in a proactive way, considering that care pathways, how much conditions cost, you have an inordinate amount of data about patients that presumably could be leveraged to help them make better decisions and reach out to them with good information instead of waiting for them to come and get it from you. We call this anticipatory design. Let's anticipate people's needs and deliver on them, again, as opposed to waiting until they've been upset to find out that something isn't covered to the level they expected, or things like that. We're also exploring now more and more the fiduciary responsibility that insurers have in terms of making sure their members don't go bankrupt. This is a new concept, right? Insurance companies really do tread the balance between health and finance. So many of our insurance clients now are looking at the financial well-being of their members as well as the health and wellness of their members, understanding that financial outcomes are tied to health outcomes and vice versa. There's a relationship between the two. So we're now moving into territory of how do you help people prepare for their deductible, understand the costs that might be coming down the road, and what can they do to optimize their usage of the health system. We just heard from Robin on how she really, took the bull by the horns and reduced the cost for herself and for her insurance company. So this is really important. How do we guide people toward making better decisions? Now, we've heard in the past, many people talking about, insurance company as big brother, and, there's trust issues, and do I really want to give my data to the insurance company, and this and that. But it's interesting because, again, insurance companies are in a very unique position to reach out to members and help them with decisions, not just financial decisions, but also decisions around treatment options, and provide them with good information. We would like to think that on the health system side of things, that there's the information and the resources and the decision support tools to guide people toward, good decisions, not for each patient, the treatment options that they have are different, and the decisions they want to make are different. But how do we help people toward the best treatments for them? Understanding that the simplest treatment is sometimes the best treatment. And how do we do that? Treading the balance between being a partner in health, but again, there's some of this still kind of lack of trust. And so we also look at kind of an adapted Maslow's hierarchy of needs, looking at, okay, what's most important to deliver to members? First, looking at trust. How do we build trust with members? How do we get the basics right? How do we be easy to do business with? And then how do we be kind, and how do we then help them to improve their health? So how do we get permission to have a relationship with them where they are trusting us to have their best interests in mind, and that we can be, again, their partner in health? Now, I've been talking about this, insurance company as partner in health for a while, and a couple of years ago, I was at an executive summit for insurance companies, and I said, insurance companies have a good opportunity to be partner in health with their members and help them achieve better outcomes, and really be proactive and preventative, and get people on the path to better health. What if people in your plan were healthier than other plans? Not because you didn't accept sick people into your plan, but because everything you do as a business, by your very nature, is set up to get people on a path to better health. And somebody I was talking to said, no, we just adjudicate claims. Like, let's not go to any funny business here. And but that's changing. That was a few years ago. And Blue Cross Blue Shield of Massachusetts is here. Humana is here, and Humana has recently made the big, hairy, audacious goal of getting their population 20% healthier by 2020. And so this is a claim that they're making, and everybody in the organization is focused on this. So this is starting to happen, and it's not just good marketing. People are redesigning their businesses to deliver on this, which is very exciting, right? So a lot of obstacles, but also a lot of potential exists in front of insurance companies. So with that, I want to hand it over to Robin Glasgow first. Robin is the head of innovation at Blue Cross Blue Shield of Massachusetts, and they have participated in the wonderful environment in Massachusetts that kind of paved the way for value-based care, as Matthew pointed out earlier. They're committed to delivering the best experience to their members, and in fact, they do enjoy really good customer satisfaction scores. We've been really privileged to be able to work with them over the past couple of years, and I've seen Robin speak before, and that's why I invited her here, because she's pretty great. So without further ado, I want to hand you over to Robin. So let me get this up for you here.
Bottom of the barrel. I tell my kids, can you all hear me okay? I'm loud. I've never been told anything. No. Mics and podiums make me nervous. Yeah, I tell my kids all the time it's hard to fall in the ditch when you're already in it. So we have a lot. We can go up, and we have a lot of opportunity to go up. So there we go. Any Toy Story fans in the room? Oh, come on. Yes, I love Toy Story. I know, I've been quoting Toy Story for a long time. And here we go. Okay, so I head up innovation. patient, as Amy mentioned, and I actually call Amy behind your back, I call you my sister from another mister. I actually view my job, just between us in the room, as putting Blue Cross Blue Shield out of business. I've been in healthcare for 25 years. I worked for United Healthcare. I worked for another Blues company. I spent the bulk of my career at Kaiser Permanente. I worked all throughout the healthcare continuum. So I'm an insurance nerd by default, I think, a little bit, and I think there's an opportunity to bring it. So, let me tell you a story. So back in the day, it used to be that a patient and a doctor had a really awesome relationship. They were an exclusive, long-term, committed relationship, just the two of them. Sometimes if something went wrong, a doctor would go to their patient's house, called a house call. And while they were there, sometimes they would treat their kids if they were sick, or give them a shot if they needed a shot. And then at the end of it, there was a bill, the doctor got paid, and the doctor went on their way. And then something happened. Somehow we fractured that pretty exclusive relationship. And how we fractured it is that we put all of these barriers between doctor and patient that has made it complicated, difficult, frustrating for a patient to get what they need, when they need it, know what they need, know how to get it. As I mentioned, I've been in healthcare for a very long time. I've been in Boston for a year and a half. And you think I would know how to navigate the system. I've designed products. I've designed health systems. I help to work on the financial component. And I cannot figure this system out here to save my life. I have many different HRN numbers. And I still couldn't tell you what my deductible is. And I should know that. These are basic products that I've developed. But all of this that's between the doctor and the patient has created a lot of confusion, a lot of frustration. And we talk about healthcare as complex. I believe healthcare is extremely complex. It didn't used to be. We've made it that way. And if we've made it complex, I think we can do a lot to take the complexity out. So how do we do that? How are we thinking at Blue Cross Blue Shield about the patient and their experience? One of the things is that we are completely frustrated and annoyed with the status quo. We think it's unsustainable, which is why in the innovation team, which is also a year and a half old, we are committed to transforming it. What the foundation of how we think about this is through empathy. We've been introducing through design thinking, any design thinkers in the room, introducing through design thinking the notion of falling in love with the problem. When you fall in love with the problem, you have many solutions. What we do, whoever has worked in a business, we think we know what our customers want. Because we ask them, do you want, we give them a choice of products and they choose between one or two. I had an executive at my former organization tell me, people love HDHP because it's selling like hotcakes. I'm like, no one loves an high deductible health plan. We don't like selling it. Patients don't like using it and buying it. I can afford to pay a $5,000 deductible. I don't like a high deductible plan. But that's what we have resorted to, those types of products, to get some of the financial month-to-month burden out of people's hands. We also, from an innovation perspective, we look at, as many of you, about health policy. And not about, for me, I don't think it is repeal and replace or whatever is flavor acronyms of the moment. I look at it, look, we need to repair it and then get the hell out of the way so that we can get back to that simplistic relationship. And we're not always patients. There are health episodes that happen between the events of meeting with your doctor. And so, as Amy mentioned, the thought of well-being, that's one of our innovation tracks that we've identified at Blue Cross Blue Shield. Very purposeful around well-being, not health and wellness. We're not looking at reward points. I have a bias that those aren't necessarily the best use of anyone's time, money, or effort. But well-being, it's the looking at the 360 view of an individual, not just their physical, not just behavioral health, social, financial, spiritual, because those health episodes happen 365 days of the year. And if we're going to change it, we have to change how we show up. We're also starting an innovation council. I have a firm belief that in order for us to change healthcare, it's not about necessarily doing things differently. We have to do different things. In order to do different things, we got to bring different people into the conversation. So the health ecosystem as it stands today includes the normal cast of characters. You have the payers, you have hospital, provider, pharma, lab, et cetera, et cetera. But it ignores, again, going back to the well-being perspective, looking at parks, recreation, retail, food, beverage, academia, other actors that interact with us as humans throughout our day. Those are opportunities for us to engage in a very different way. As I think you mentioned too around digital, what if we didn't have a website? My email is filled with people trying to sell me shiny stuff. I love shiny stuff. I love bling. I love my iPhone, iPad. But healthcare is not going to be fixed with an app or a portal. That is one of the last areas of effort that I'm looking at, because we have to radically transform the process and then come in with the digital solution to enable it. Financially, this is a short comment. This is ridiculous how much healthcare costs. And the only way for us to, I believe, to get cost out of the system is for us to change the system. We have to change the way that the costs that the premiums are derived, the notion of the supply and demand. That's an antiquated model. We are below or hanging out with the Comcast of the world for a number of reasons. One, because we're, I think, one of the last industries to really embrace innovation. Innovation has happened a lot in the care delivery aspect, but not so much in the business of healthcare. And so for us to get cost out, not just in the care delivery model, about getting shorter bed stays and making sure we're doing those things around prevention, the business of healthcare has to radically transform so we can put money back in the pockets of consumers, of patients, and others. And then lastly, I'll end with this, is that I always say that as soon as the consumer figures out that they have the power, I think a lot of this will change as well. Whenever there is a consumer uprise, there's many examples of that, that's when the world change. And I think once the consumer realizes that they have that superpower, we'll see a lot of change in our system. So with that, I will hand it back over.
Sorry. Thank you so much. And I have a bunch of questions for you.
I know you do. I know you do. I'm sorry.
But yeah, these are really swivelly. So Callie is from Humana, and she's up next to discuss how they are innovating from the inside out to improve things in a unique way, I would think. So would you like to share with us what you have going on?
As a whole, or
as a whole. Do you have a presentation?
You want me to do it?
Yeah.
I'm like, is this a question? I have a presentation. I have lots to say. Can you guys hear me in the back, or do I need a mic? Are you good? Okay. So can somebody in the back, if I start to get quiet, can you just put a thumbs down to me? Okay. So my story. So Amy, whenever she reached out, I said, well, what do you want us to talk about? And she said, well, just talk about what you're most passionate about. And for me, I've only been in healthcare for about 6 years, and I actually was in financial services before coming to healthcare. You'll hear a little bit about that. But I'm most passionate about making healthcare more human. So I'll start with a story. My team laughs at me because I tell stories for everything. I don't know if it's a Southern thing or if it's just a Cali Bowman thing. But I actually think in stories, and it's my way of making sense of the world. And so this story actually goes back to when I was a financial advisor in St. Louis. And I promise it's relevant for the conversation we're going to have today. So to set some context, when I moved to St. Louis, I was building a financial planning practice. I knew absolutely no one except my husband. I had no personal relationships, no professional relationships. So the first thing I did, because I knew in order to survive professionally and personally, was to build relationships. So the way that I did that was to go around to local restaurants And these local restaurants are like, you know, the ones that are on the corner, they've been there forever, people know the owners, they're like a part of the fabric of the community. And I'd go in and I'd introduce myself, and I'd ask them, and this is one of my favorite ones. It's Hindle's, it's actually in North St. Louis. And a little town called Florissant. But I would go in and I'd say, can I buy your best patron lunch? And I was like, the patron that sits in the same spot, you know, when the waiter or waitress goes over to talk to them, they don't even have to ask what they want to eat because they know. I want to buy that person lunch. I did that for a year. Coincidentally, it's how I built my practice. It's also how I gained 20 pounds in a year. But it was incredibly fun, and this is how I met and built my practice. I did it for probably about 2 years, and then I could no longer do it. I needed to start exercising and stop eating. But one of my favorite clients came actually from this restaurant. And anytime that I sat down with someone, I sent them home with homework before they would come over and talk to me. And the homework was always, what are your dreams? What do you want to do with your money? Because I found in financial advising that people don't earn money. You don't wake up and go to work every day to earn $1 for $1 steak. You earn it because you want to do something with your money. And so I'd send them home. I'd say, go figure out what is it that you value, what really matters to you in life, and what are your dreams. And this couple, you guys, they walk in my office, and they were grinning ear to ear. And it was like, they were like kids in a candy store, like kids about to hand their parents a straight A report card. So they sit across the table, and they wanted to do retirement planning. So I said, okay, well, what do you want to do in retirement? And in the same moment, they said, travel. Oh, we just want to travel. We've had so many kids, and we've never, sports, and we just haven't been able to do it. And I said, oh, wonderful. So tell me more about that. What does travel look like for you guys? The husband started off, and he said, I want to rent an RV, and I want to drive anywhere that RV will take me. He said, just go wherever we want to go and stop when we want to stop. And the wife looks at him with, the disapproving wife stare. I make this face a lot. I know what this is. I recognize it easily. So she makes this disapproving wife face, and she's like, no. We're going to travel to Europe and Asia. We're going to get on a flight and go to Africa. So first life lesson, that if you take the time to ask the right questions and to listen, this is sometimes hard for me, but to listen, and then the discipline to turn whatever those problems are that you hear into solutions that are acutely tuned to people's needs. So I learned that back in when I was a financial advisor, and I think it's extremely relevant for what's going on in healthcare today. So career took a very, very unexpected turn into healthcare. And truthfully, I'll tell you guys this, I thought I would hate it. I planned to stay a year, and then I was going to go back to financial advising, but I fell in love. And the reason I fell in love with healthcare is because the opportunities are endless. I mean, even the language that we use, pharma, our payment models, the experiences we create, the services we deliver, it's almost overwhelming. So I'll tell you someone else that I met in healthcare that's really shaped, I think, how we look at healthcare innovation in Humana, but also personal. You guys know these people. They come into your life. You may meet them on a street or in the coffee shop, and they shape your life forever. They probably don't even know that they've done that, but they shape your life forever. For me, this is Jacques. So let me tell you a little bit about Jacques. And truthfully, I have actually never met Jacques. My team was doing research down in Florida on a program we were developing for people that, I'm getting emotional. I'm also pregnant hormonal, so I might cry. He lived in Florida, and we were doing some evaluative research on a program for people living with congestive heart failure. And Jacques taught me a couple of things. First, that it's not just about asking the right questions and not just about listening. You have to be willing to put your ego aside. Don't fall in love with the solutions. You've got to put your ego aside and be willing to be wrong. And for me, this interview happened years ago, right when wearables were coming about. Everyone was talking about getting your steps in and being healthy, and if we can make data more transparent, the people are going to want to get healthy. Well, Jacques and many others in our research proved that that's wrong. And so for Jacques, what he taught us is that it wasn't about getting healthy for his personal sake. It was because someone was watching him. And that really mattered to Jacques, because that takes me to my second learning. It mattered to Jacques because that meant that someone loved him. And that's, like, that alone was like earth-shattering to me. Because again, I'm Humana. We're below the Comcast of the world. We can give people scales and a customized program that's woven into the fabric of the community, supported by clinicians, integrated into providers' offices, and that communicates love. And he went on and talked about, and this is a quote from him, if you're watching me, I know it's because you love me. And it has forever shaped the way that we build products and the way that we develop solutions, because there's a nuance in even the words that we use to discuss healthcare. We use words like the health system, but really it's health care. And that simple nuance in the way that we talk to each other is really, really important, because when we take ourselves out of the picture and you think about delivering heart surgery or even insurance and its fundamentals, protecting your family from catastrophic loss, is love. That's what healthcare is. And so what I'm most passionate about is making healthcare more human. It's what it's a journey we've been on for, probably 6 years as a company. But that's really what we're trying to do. So let's move over that slide. So the question I'll have is, how can we change the conversation? I'm a pair. There's startup companies, there's public pharma, there's policy, I think somewhere in the back. Build radically simple experiences that enable people to live their best lives. Because that's what I'm most passionate about, and that's the conversation I hope we have today.
Awesome.
I don't know if you felt something.
Maybe, yeah, there we go. Sweet. Now you know why I love these ladies, right? Yeah, you know. Okay, so I have a ton of questions. First, thank you. And I'd love to know, so when you are fighting the good fight, you will come across lovers and haters and all sorts of people, but there are obstacles, right? There are whether it's a policy, whether it's culture, whether it's a certain person or a team of people, you will come across obstacles. So I'm wondering, you've been at this for a while, right? What is the obstacle right now? So wait, no, I want two. I want one obstacle that you broke down with the sheer force of your determination. Like, so an obstacle success story. And then I want the obstacle now that you're like noodling over and trying to figure out, and that you really think needs to be knocked down in order to make progress in the direction that you're talking about.
Sure. Obstacle that I broke. So the love-hate is very interesting. We also have a saying, we like to go where the love is. I have a business background, and usually and I have a consulting background, so normally when you go into a situation, you're going into the problem and you're fixing the problem. That's where we focus our energy. We flipped it, and when we started innovation area. Let's not go where the problem is. Let's just go where people are energized and want our help, love, and are already primed to adopt some of the human-centered design that we're talking about, and will become evangelists for our cause. And I share the same sentiments that Holly was talking about in terms of the human component. And we started there, and I say we're not at the tipping point. The tipping point is insight in the organization. We're not at that yet, but it's insight. And I'll say the obstacle that I overcame was one of the haters who has a very, very high position in the office or in the organization, and controls a lot of the organization. There's someone here from my Hey, the prospector. She knows what I'm talking about. Any event, classic hater, and was I will never come. We do boot camps, and I don't buy all this empathy. I don't. That's who says this stuff works anyway. I was like, huh. Won't talk to you. I'll talk to you. And eventually, what happened is that more success stories were happening, and people were sharing them. We were obviously funneling them into the organization. And 32 days ago, I got an email. Hey, I want to talk to you about potentially doing some of this work on this particular project. Score. It's score, because you break that one, the tipping point is now behind us. So that's one that overcame.
32 days ago, how many hours?
Yeah.
Gosh. And this sort of relates to where you're going. I think insurance, because the second part of your question was about, I think, sort of big one that is unmovable that kind of keeps you up. I think payers and insurance in general is really kind of in this identity crisis moment. Insurance itself is kind of becoming a commodity. I mean, margins are capped, and it's a pretty tough business to be in. And so, but traditionally these big payers or these big insurers are trying to figure out, how are we going to evolve and how are we going to stay relevant and how can we use all of this data that we have about our customers to actually make a meaningful difference in their lives. And at Humana, we call that bending the trend. Particularly because of all the chronic illness that's happening in the world. So it isn't just about, keeping people healthy. It's about actually reversing some of these chronic conditions and keeping people, slowing the disease progression, keeping people healthy for longer. And so that struggle between, are we an insurance company, or are we really in the health business, the healthcare business, and what does that look like, is something I see lots of insurers really struggling with. That kind of ties to the first question you asked around your personal, like this mountain or barrier that you busted through in similar years. We have this gentleman in our company. He is like legend at Humana, extremely brilliant. I put him in like top 3 people at the company who know the most about our organization. He's not a naysayer, or is never really rude, but not totally bought into innovation or human-centered design, or even this notion of orienting a company around customer pain points. And we were in a meeting, and we had this big poster, and we're showing people how this experience that we had inadvertently designed, Humana had inadvertently designed this experience, and it was awful. And the most profound thing about that story was that it was an experience we intentionally created, not one that we messed up or not something that we got wrong. So of course we're in front of probably 100 of our top executives, had this big poster up. The poster falls off the wall mid-meeting, and it's like it's crangling, making all this noise, and it's falling. I'm like, oh my gosh, this is terrible. It's horrible. Our poster is falling. We don't have anything to talk to. And this executive, he gets up. He's probably about as far as you are. He gets up, walks over to the poster, hangs it up, and he's like, "You 5 people, come help me hold this up." He was like, "This is really important." He's like, "This matters. Are you guys okay with running an organization that does this to people?" And I was like, "Preach, brother." And it was this really, I had like 16 people text me after that meeting. Was like, that was a moment. Like, that was a moment in the company where this legend has got up. I wasn't speaking. He got up and rehung our poster and was preaching about the importance of why that matters and why we have to work differently and think differently. And that happened 33 days and 24 hours.
Well, to answer the second part with the greatest obstacle. So one of the, as I mentioned, one of our innovation tracks is around health policy. And it's funny, there's 2 people in our organization, one who works more on the federal level and one who works in the state. I started my conversation, I said, this is a federal person. So I want some way to get blanket immunity so we can try all this weird stuff, because everything we're thinking about is illegal. And so I want blanket immunity to allow us to try. We're a responsible organization. We're not going to cherry pick risk, and we want to get other responsible organizations. And she's like, well, tell me which product you want, and I'll see if I can get a pet. I'm like, wrong person. Then I went to the state person, and I said, look, I want blanket immunity, and I told him, and I think I'm about 20 seconds into it. He said, this is why I got into healthcare. We're going to do this, and let's call it a demonstration project, and we can do this and do that. So it'll take time to set it up, but once we get it, you're good. And we have a good relationship with the state, so if there's any... thank you. I'll see you later. Yeah, it's really, and I'm not kidding when I say inviting other people into the conversation. Complete transparency, but we got to get out of that business of all the barriers that are in the way, and let's try different stuff. And we're playing in this sandbox right now that's so limiting. And we think of cool ideas, but we can't do that because it violates HIPAA or whatever. Yes, all the many different things that it violates. If we're able to if we were to land on Mars and create a new system, we wouldn't have a lot of the stuff that we have today. So let's try and get to that area. So that's one that we're not there yet, but there's light.
Yeah, what you're saying is it reminds me of what I said yesterday, which is our system was designed by default, meaning it wasn't designed with intention, and moving forward we need to design it with intention. But I got a visual when you were talking about like a maze, right? And you come against this wall, and I think some of us we just keep banging our head against the wall instead of like trying to find the wormhole, which is the light of somebody who will back you up. So finding that ally and not taking no for an answer. I once heard somebody equate innovation and the challenges associated to death by 1,000 no's. And it's like, well, you got to get past all those no's and find the one yes, because that can be truly transformational. I want to key in on both of you kind of alluded to collaboration. I do think collaboration is a new innovation, but I'm wondering, in terms of collaborating with others inside of your organization, but also other stakeholders in the ecosystem. So, you mentioned the scale, and I think doctors were involved in that somehow. You mentioned, collaborating with the state and in terms of policy innovation. How do we actually do that, right? Because there's a lot of fear and trepidation, and a lot of innovation folks aren't necessarily connected to the folks looking at partnerships, and it's like, oh, are we really going to collaborate with a pharma company? Are we really going to collaborate with this health system? So how are you approaching facilitating collaboration with other departments in the organization? Is it strategic selection? How do you go about getting the right people to the table internally, and then trying to get people to the table externally to explore, how do we get our collective stuff together so that we can get on the path to simplifying this whole mess?
Some of the most interesting work that I think Humana is doing right now is actually in local communities. That's what's making me think of. So it was probably about 3 years ago, Humana launched our bold goal, which is to get every community we serve 20% healthier by 2020, and that's including our associate population. And I loved what you said yesterday, Amy, that we have to get out of this notion of design thinking and design doing. And Humana, when we did that, we went into several different cities: San Antonio, Knoxville, Tennessee, Mississippi, and we went into this community and we started design doing. So instead of talking about collaboration, we brought together policymakers, some of the biggest hospital systems, pharma, community, nonprofits, and got them together. And we do it twice a year in these big cities that we go to. And out of those sessions come subcommittees, come initiatives, and that's really how we go about making the communities we serve healthier. Because it's not just, you guys know this, it's social determinants of health. It's about, your parks, it's about the zip code that you're born in. So much of health doesn't actually happen in the healthcare system. It happens outside of the healthcare system. And so enabling cities to be healthier, enabling, one of the most innovative partnerships that I was fortunate to be a part of was a partnership between Humana, HEB, which was the biggest grocery store in Texas. It's like the most beloved brand in Texas, and one of the biggest provider systems. And the providers now write prescriptions for groceries that is actually paid and reimbursed. For pregnant women on Medicaid, it's actually reimbursed. For folks in Medicare, it's you write a prescription. If you have pre-diabetes or type 2 diabetes, you can go to the grocery store, get a tour of the grocery store, you get counseling, you get food covered, and it's actually a part of this healthcare ecosystem that we've created. And that's been about 3 years ago. And so that's really scaled beyond that. But those are the types of partnerships it's going to take to really start to innovate in the system.
Yeah, and we have something very similar that we're doing, particularly around food. But one of the things that I've noticed, as I said, I've been in healthcare a long, long time, and I didn't just adopt this mindset. I didn't just adopt what I think now. But I used to say what I'm saying now 10 years ago, and most people thought I had 9 heads, and I was just crazy. And what I found that there are more people that are like, this is exactly what I'm thinking. We need to figure this out. So externally, it's very easy to get people who want to play for the right reason of making it better, getting costs out of the system, ensuring that this is a human experience throughout, making it as simple as possible. So that has been a pretty exciting thing to do. It's interesting internally. It's harder. It's a little harder. I think people are there for the right reasons. I mean, it's just change. Typically, it's harder in institutions that have historically been around for many, many, many years and are used to doing things this way for many, many, many years. So it's a little harder in terms of the collaboration, but the same mindset of going where the love is. We find those areas that are strategic and critical for us to advance. And thus far, there's been a few, but that email that I got 32 days ago has made it's night and day. It's night and day. So I think we're not short on ideas on how to really transform it, but it's really, no one I don't think has the answer. I do believe the answer exists somewhere in some other industry, maybe some other continent. It just hasn't been applied in healthcare because of the HIPAAs and CMS and all the regulatory and the complications that we've added to it. So my journey around collaboration is finding those people who believe, finding those people who have successes in consumer experience, not in healthcare, and around financial well-being, obviously not healthcare, who have experiences in doing these things. Get them all in the room so we can design these things.
Yes, move beyond design thinking into design doing. Make t-shirts for you.
Design did.
Design did done that. So let me see. So I have two kind of concepts that I'm wondering if they go together, and I'm just going to kind of go with it and see where we end up. But we've heard of health systems and insurance companies. You're built to manage risk, right? On the health system side, quality matters, safety matters, and so there's all these processes to avoid risk. In insurance companies, y'all are built to avoid risk, right? So to try to insert innovation into an environment that is naturally risk averse, and in fact, that's how the business survives. Is difficult, right? So I've heard stories, people tell me about how they put an idea out there and it failed, but it failed for a detail that could be remedied. But because the organization is afraid of failure, they throw $1 million project out the window because they don't want to iterate. It's just like kind of coin it a failure. It made me look bad. It's a failure. Let's just get rid of it and move on to the next thing. So my point there is about, kind of culturally, in a risk-averse culture, how do you promote iteration, right? But it also gets to the point of incremental innovation and disruptive innovation, right? Can you incrementally innovate in health and get us where we need to be, or do you truly need to disrupt? And if you truly need to disrupt, then do you do it kind of skunk works on the side with a cloak of immunity or invisibility or whatever you've got going on? Or, does it have to be within the constraints of the organization? So we've seen, organizations like United Healthcare and Harkin, try to kind of invent something new, and it gets scrapped, or so my question is, risk averse cultures and disruptive versus incremental. How do we actually get there?
So I think of, so as I mentioned, we start from empathy, and it's not just for patients, consumers, but it's also for people inside the organization that are doing work. So one of the things, and I don't know where all of you are from, but what I'm about to say, I know you can attest to, which is typically when there is a problem in any business with more than one person, if there's a problem, that person voices the problem. And they might voice it to a colleague, voice it to a friend at work. Eventually they might voice it to someone who can do something about it. Nothing happens to that problem until it becomes that burning platform. And then it's a burning platform, and then it's decided by the people that sit in Mahogany Row that we're going to do something about this problem, and they assemble a task force, and the task force meets, and they meet, and they reschedule a meeting because Tom couldn't be there, and then they meet. They try to figure out scope creep. They go back to, why are we doing this? Hank comes to the meeting and says, I don't like this. You go back to square one, and then, okay, you finally get something that's produced. PowerPoint version number 32 is presented to the Mahogany Row. They do a lot of nodding. You're almost out of there, and someone says, I don't know why we're doing this. This is competing with this particular priority. So you got to go back and fix and re-emphasize your point, and then you come back to the group. Okay, you got the stamp. Then you have to go to IT because everything touches IT. You got to do needs requirements. You got to get the meeting. You got to get the meeting. You got to get Tom because he wasn't there, and if Tom doesn't buy in, then you got to come back. And then you finally implement. You have to wait because it's a 1/1 effective date, and you can't get into the system. That's 3 years from the moment that someone right? Y'all see what I'm talking about? Yeah. And so I tell that story internally to people because whether you are owning the process as a COO, a EOO, or whatever OO, you can feel that pain. Whether you're the person that's doing PowerPoint version number 72, you can feel that pain. It's a pain that everyone has, and that costs money. I always talk about, this is an expensive meeting. There's 40 people here, and we're just talking about talking. We're not even design thinking. We're just pontificating. And so what I talk about here is another way. And another way would be, I have a problem, I go to my colleague, we talk about it, we do a quick sprint. It could be 20 minutes, 2 hours, 2 days. And that sprint includes going out, building a low resolution prototype, talking to people, talking a lot to people, talking to extreme users, so to your risk point of, in human-centered design, you can't just talk to that target market. You have to talk to the extremes. If you look at the bell curve, talk to the extremes. Sorry. Talk to the extremes. If you can address those needs, you might address the mass of more than just your target market. And then you can go to someone. It's kind of a reverse business case. I talked to 100 businesses who would be willing to buy this, who have tested this for 30 days, and it cost me $15,000. Would you invest your money in that? And now we're talking about spread versus that business case that took 3 years and is using old data probably and hasn't necessarily been tested and doesn't have the buyer. We made some assumptions there. If you had $1 to invest, you would invest in this. This took maybe 2 months. This took 3 years. And so I just had a meeting 2 days ago where we were doing a sprint report out, and one of our Mahogany Road person said, well, I think you guys should put together a business case and then come back, and I turned to him, I said, this was the business case. I said, I don't have to ask for permission, do you? And I just put him on the spot. And he was like, well, no. It's like, well, let's just do it. Let's do it. They're already there. The finish line is right there. Let's run.
Do you do career coaching?
Yeah, it's called wine.
How about you, Kelly?
I've done. It's tough, and big companies that to manage Humana's been around for over 50 years. And insurance in general, I mean, we make money off of managing risk. So this notion of going fast and making mistakes and failing fast and all of the buzzwords, I mean, it's like in the DNA of the company to avoid these types of things. And so for Humana, it's been, I'd say, this cultural journey that we've been on for quite some time, you know, reshaping our values, building cultural competencies, building an innovation center, hiring design folks. It's been quite a journey. My personal bias is to always demonstrate by doing. And so I've seen in Humana, we can spend a lot of time talking about debating what are the right words to roll out these new values and to demonstrate, you know, version 32 of a PowerPoint presentation versus I could put together, like literally sketch on a piece of paper and demonstrate to you the power behind this idea or this concept that we're trying to push forward. And my personal bias is to demonstrate by doing. And so you'll get a lot, I found in Humana, we'll get a lot further, faster, showing people why experience matters. And if you solve for customer and provider pain points, how that will influence your processes and how that will change your technologies and how that will a lot of times need to change how you're organized as a company, your org design and the talent and the people that you hire. And literally just one little concept and weave that story and show people how, if that domino falls, how these other dominoes fall, then people's eyes start to open up around, okay, yeah, we are gonna have to start working differently. And yeah, this experience stuff isn't just fluffy, nice to have, first thing to get cut from the budget kind of stuff. It's meaningful stuff that if you really want to transform your operation, it isn't fluffy, and it isn't, you know, designing new experiences. It's designing new organizations.
So my final question before we wrap, I could talk to you guys for days, and I did enjoy it. So final question is, you know, there are so many problems to solve, so many areas of love to explore. And it gives you a really long list, right? And how do you prioritize that list, and what are the metrics that matter? Because we know that the things that measured are what are the things that people pay attention to, and whether that's HEDIS measures or new measures, NPS scores. So I'm wondering how you feel about measurement, and what are the measurements that matter, and have you introduced any new measurements that you think are really gonna, you know, head people in the right direction?
So I'm a data geek. I come from financial services where I could literally measure you know, I knew every call I made, you know, every person I met, every meeting I held, you know, what that meant to the bottom line. So I personally love measurement. I think we've got to be very careful of this concept of go, no go. You know, a lot of times we'll say, okay, well, these are our success criteria, and if we don't meet these success criteria, we cannot proceed and the project must die. That I look at measurement as a way to learn. So again, if you fall in love with the problem and not the solution can die a slow, painful death, or it can die a fast, fiery death. But you should always come back to the problem, and your measurements and your, you know, success criteria may not change because you should be solving the same problem. As an organization, we are having a lot of debate right now around this notion of quality in healthcare. We have quality scores and our HEDIS and our STARS measures, but we've not yet talked about like the quality of service or the true customer or relationship quality of the products and services that we're delivering. And it's actually why I made my most recent career change into service experience design. Because as an insurance, I think we still are we're innovating on the fringes. You know, we're developing new products and new services, but we've not yet changed or really had the courage to tackle our fundamental, the core, the ugly, nasty, you know, parts of our business. And for us to really not just design new experiences, but design new organizations, you've got to really start to innovate from the inside out. And so that's looking at claims adjudication. That's looking at your call centers. That's looking at all your internal processes. That it's the ugly, not sexy stuff that I've been doing, but it's the stuff that really matters. In a operations world or in the insurance world, you're going to get nowhere without measures.
Yeah, I look at it, I don't know what the measure is yet, and I'm someone who spent a lot of years doing strategic planning, so you're looking at, measures that go with that. And coming from Kaiser Permanente, quality is, that's printed on your forehead, so you can read it on the other person's forehead. I want to find a measurement that is focused on the end user, and from my lens, it's the consumer. And I say consumer because patients are subsets of consumer, and we're all subsets of consumer as payer, as provider. So how are we improving and making the lives better of the consumer, of the individual? I don't know if the measurement is of that yet, and like the comment from Jacques, those types of things. So it might be more qualitative than quantitative. I don't know, but I think until you think of other successful businesses that people just love and they're happy, may not be in healthcare, love, happy, they get what they want, their expectations are far exceeded, it doesn't put them in financial ruin, and why can't we do that?
Yeah, I love that. In fact, one exercise we use sometimes is future state persona. So here's the current state persona and their obstacles and their struggles and their challenges, but future state, what does this persona look like? And use what would a consumer or a member write if they were writing a love letter? Like, what's the future state love letter that we want to be getting from members? And I actually was at a oh God, where was I? It was a, not AHIP, maybe AHIP. Yeah, AHIP Innovation Center. Yeah. And we were talking about measures, right? And HEDIS measures, did someone go get their A1C tested? Yes or no? If they did, you're successful. Here's some cash money and all of that, right? But if somebody gets their A1C levels checked, it doesn't necessarily mean their diabetes is getting better. So what kind of measure is that? And I wonder, and to your point about what do consumers and members really want, we talk about self-reported data. It's actually important what people report about their quality of life and their energy and their mood and everything else. There's that data is important. So that's data though, but what about patient-defined outcomes, member-defined outcomes? What are they expecting from us? What outcomes do they want from us? And help them define so that we're designing ourselves to serve them, and instead of assuming what they want, right? And I think that's the mojo of what you guys were talking about. But this is so good. Thank you so much for sharing your stories. And these ladies will be available after if you have any questions. So thanks. All right. All right, so with that, we're going to transition to the next part of the session here. And in this session, we're going to be talking about, and if our wonderful speakers could please take their swivelly chairs, that would be wonderful. So in this session, we're going to be talking about navigating the health system. So when we think about navigating the health system, I like to think about it in two ways, but there are obviously more. Think about the health system right now. The patient is left in the center of a disconnected ecosystem to navigate on their own. And they need to figure out, okay, what's going on with the insurance company? What's going on with the hospital? What's going on with my care team? What's going on with the pharmacy? What's going on with my acupuncturist? Am I going to take vitamins? I just did something with Amazon. I'm trying to change my diet. All of this stuff is going on, and they're trying to figure it out and navigate it, right? And there's the kind of mechanics of health, making the appointments, showing up for them, making sure you didn't eat before the lab test is drawn, and if the appointment's canceled or you need to reschedule, and how much is it going to cost, and the financial aspect, and is this covered, is it not covered, is this the best person for this treatment, and managing the administrative part, the logistics of health, finding the best doctor, the best treatment, the best, and understanding the costs associated, right? So that there's that part. But then there's also day-to-day. People have 7 minutes with their doctor, but they're 24/7, 365 caring for themselves. And so how do we help them navigate their own health and understand themselves and what's working and what isn't, and what can they do? So there's sort of those two aspects, the system and navigating that, and then health and figuring out that and what works. So these wonderful speakers will be sharing with you what their organizations are doing in terms of services and technologies to help patients and families and consumers in this realm. And as somebody said yesterday, I think it was Casey Quinlan, you sort of, you don't pay attention to health until you're not healthy anymore. And by then it's like you don't have time to understand it because you're busy being sick. So hopefully you guys have some solutions for that. So I'd like to welcome first Justin. And so, each of these speakers is going to speak, and then I'll be following up with questions. So.
Great. Great, while it's pulling up. Hi, everyone. I'm Justin Durack. I'm VP of Product at Collective Health. Yeah, that's the last slide. And we're done.
That was wonderful. Thank you.
Yeah. It's been great. Cool. Thanks. Quick intro on myself, and then I'll dive in. So I've been leading product at Collective Health for the last 3 years. Before that, I'm an engineer, entrepreneur, and sort of generally, I still feel like I'm new to healthcare, still figuring this out every day. But really excited to be here, share a little bit about what we're doing at Collective Health, and then join the discussion. Just as a quick primer for me, who here has heard of Collective Health or has some idea of who we are and what we do? Okay, cool. So I'm going to kind of start from the beginning, give you a quick intro on our mission, progress we've made so far, what we're working on. And I'm also really going to focus on our approach for how we're building products, which I think is important and relevant for this discussion. So I'll start at the beginning. So we were founded in 2013. We're in San Francisco, and we were founded based on a personal story. So our CEO, Ali, had an unexpected health event, and he had a twisted intestine that put him in hospital. Otherwise healthy guy that suddenly dove into healthcare, and he thankfully got great care, made a full recovery, long story short, and afterwards ended up dealing with this months of aftermath. Really trying to sort through piles of paperwork and this huge amount of bills that were not being covered by his plan, despite what he thought was having great coverage from his employer. So months of paperwork, lawyers, extreme expense, and just immense frustration and confusion. And it's that story that we've heard here at the conference so many times that is all too familiar. That situation of being both vulnerable and dealing with your health, and maybe getting great care in doing that, hopefully, but then at the same time also having to deal with your health care. And that in itself, all of the other stuff that isn't the actual life-saving intervention, all the other follow-up and the pain and confusion that comes with that, was really the problem that he decided to tackle. So he called his friend Rajay Bakniji, who's a doctor, health economist, and they started digging in and asking why, and really getting to the underlying causes. What is going on underneath the surface that is actually manifesting in all of this, end user frustration, pain, confusion, and coming at it with a bold approach for, okay, if we actually want to make it effortless to understand, navigate, and pay for care, which is our mission, what do we need to do to actually make that work? And that's really what I'm going to focus on today is a bit of the how. Here's one way we say it, is becoming the data and financial backbone of healthcare. I'm going to focus a little bit more on the product side of it for how we're building what we think are really different solutions. I'll orient just a little bit more briefly on what our solution is, where it fits in the overall space, and I'll tell you more about the products themselves. So we offer an alternative to traditional health plans for self-insured employers. So these are employers that are a little bit larger. Our sweet spot customers are usually between 1 and 10,000 employees. And they're self-insured, which some of you may be familiar with, but basically they're running a mini insurance company. They're actually managing their own risk. They're directly paying the doctor bill for their employees and dependents. And we found this market. It's a huge market. It's over $1 trillion of spend each year is going through these employer markets. And that's where we found the sort of the best innovation bed for us to actually provide a better solution, because the incentives are really beautifully aligned, right? You have an employer who really cares about the cost, quality, and experience. Again, they're managing their own risk, so it's directly out of their bottom line. The quality of the experience, they want to offer something better to their people. They're trying to attract and retain the best talent, and the actual health outcomes matter because they try to do what their company is doing. They need really productive employees who are focused on that and not on managing their health. So you have all these beautifully aligned incentives. You have a company which is running a mini insurance company inside itself alongside of whatever their main business is, and they don't have the right solutions to actually achieve their goals. So this is where we focus. And what we've done is we've pulled together all of those different pieces, and there are lots of pieces that comprise the health benefit solutions that employers are trying to offer. And we've put it all together on one platform. So medical, pharmacy, dental, vision, spending accounts like HSAs, FSAs, data reporting, concierge member experience, program integrations, all of it running on a collective health platform. So just to make this a little bit more visual. So what does this actually look like? So if you're a member, which is either an employee or a dependent on one of our clients' health plans, then Collective Health is your one-stop shop. You come to us for everything. So we're this end-to-end experience. And we offer all of the touch points from paper to digital to service at any point in the journey, choosing your health plan, finding a doctor, understanding your claims and coverage. You come to us and we take it from there. So it's just a quick tour. We have an integrated web portal, so members come online to us to actually answer any of those questions related to any of those different services offered by their employer. Really clear, readable communications. So when we process a claim, we send a statement that people actually finally understand. Oh, okay, this is why I owe that amount of money, or oh, that's what my deductible does. The basic stuff that is still extremely confusing for most people. And support is huge for us. So member advocacy is what we call that layer of support that we offer to our members. And it's all in our office in San Francisco. We have incredible folks who are on phone, chat, email with our members. And they're really incentivized to sort of do open-ended problem solving. There's no scripts. They just pick up that phone and say, how can I help? And lastly, sort of highlighting mobile is still, it's important for everybody. We're seeing lots of engagement here. We're putting solutions literally in people's hands with native apps, iOS, Android. What you see here is actually just a screenshot from something we launched recently. Is this idea that submitting a claim should be as easy as snapping a photo. So that's something you can do now in our apps. And I flew through that super fast. There's lots of great demos and experiences we usually show on that stuff. I'm going to move past that because what I really want to talk about is the approach to how we're building those products in the first place. So just trust me that if I showed you the full demos, they really are these sort of really carefully designed experiences for our members. But really, that's only the tip of the iceberg. And what I'm going to focus on is how we're actually enabling that with all of the stuff that you don't see. So this iceberg analogy is one that we use a lot at Collective Health. And what it means to us is, and again, it goes back to that founding story, is what's all the stuff underneath that is preventing us from offering a better solution? So the sort of original hypothesis for the company was, if we want to offer something that's fundamentally different in terms of what people experience, you can't do that by simply putting a nice UI layer on top of the same old stuff that's out there. You do actually have to rebuild the whole thing from the ground up. And so that's what we're doing. I'll give you an example. We actually adjudicate claims. So we receive that claim that the provider submits, and we process it in our engine against a structured plan design. And we have a clean, normalized, accurate source of truth for what is that claim and what does that member owe. And you saw that statement earlier. That allows us to both message that to the member in their statement and answer any question that they may have about it with accurate, timely information. We also manage eligibility and payments and a lot of these systems that we've spent the last few years building that the more you look at them, the more complicated they are. But we didn't have to take all that on. We could have partnered with other solutions and sort of received data feeds and then tried to represent that better to the user. But that's not the approach we're taking. We're actually investing in the infrastructure to do all that ourselves so that we can then provide that different type of experience when someone's like, just tell me what the hell is going on. Is my dependent enrolled? What do I owe and why? And where do I get started? So I can't show you all that stuff because it looks like really complicated workflows and data integrations and robust code that manages missing or inaccurate data, tons of integrations. So it doesn't make for the best presentation material. Instead, I'm going to give you a peek at something that people usually don't see. So still under the water, but a little bit more visual. This is just a snapshot of one of the tools that we build just for ourselves. And this is a product we've codenamed Falcor. This is just an internal tool that our member advocate would use when they're on the phone with a member. So, so this is their interface to give them all the information at their fingertips to answer whatever that member's question may be. This is a really exciting design and engineering project, sitting down and doing research, sitting sort of behind that member advocate, listening and watching all the clicks that they're making, and trying to figure out how do we efficiently get that source of truth data we have from investing in that iceberg into that member advocate's hands so they can provide that great service experience. And every click matters because that's the difference between saying, yeah, I've got your answer right here versus, sorry, I can't help you, I got to put you on hold or get back to you later. And the short story of all that is it's working. So we do have an incredible NPS score, or Net Promoter Score, that puts us in line with the top consumer brands, the Amazons and Apples of the world. And we're doing that for 75,000 people with an incredible service experience and this digital solution that's increasingly helping members get answers for themselves. I'm getting the stop now sign here, so I'll try to wrap up quickly with a little preview of where we're going next. So all of that infrastructure that we've built is not just to do things better, but actually to enable us to do things completely differently. So what we're starting to work on now is we were excited to launch earlier this year a product called CareX, and this hopefully will be a good topic for discussion later maybe, is our solution to actually connect the right member to the right care at the right time. So really diving into that navigation problem. And what we're doing is taking all of that core data that comes from those infrastructure investments that we've made, that clean, accurate representation, the source of truth for what's going on, layering on intelligent, yes, AI-powered analytics to actually find signals in that data that can predict a member care need and help us then identify what the right care is for that member. That's a huge step, but it's still not sufficient. So what we're doing is then connecting that member with that care through our service experience. So we have methods of reaching out to that member, or when they're reaching out to us, again, with any question related to their care, we have that signal in our member advocates' hands. We're also staffing up licensed clinical social workers to help deliver that navigation message to help that member find that right care. So it's that coming together of all of that infrastructure, the intelligence, and that service layer. So we're still hearing from our members that they love the experience that they're getting, but what we're starting to see now is that we're actually taking that next big leapfrog into intelligently helping them navigate and doing it in a way that's dynamic to the environment that they're in. So whatever the programs are that are in place for that employer, for telemedicine, One Medical, Grand Rounds, diabetes management, our system underneath can then identify this member should be using this program, and we can seamlessly integrate that right into that human experience so they get that care that they need, pull the data back out for what did they actually engage with, and retrain the system to help members more in the future. So that's a quick preview for where we are. Thanks. I'll stop there and look forward to discussion.
Thank you so much. Up next, actually, is Greg Miller. And Greg's from UCB, but a pharmaceutical company based in Belgium, but you have a kind of a side project to share with us, right? So I think there's a video that you're queuing up, but did you want to say a few words before that?
Yeah, so just before we start the video, I think we are in a session to help patients navigate the system, and we heard that technology and digital, etc., is only one potential enabler of that. Actually, we decided to go the other way, the other extreme, and not to use digital, not to use technology at all, but to start with a clear insight or assumption, which is the best way to help patients navigate the system is to ask other patients who have gone through the system before that. So what I want to share with you is an experiment that we're doing at UCB globally, which is leveraging the power of peer support. And this is very important, and you were asking earlier about potential disruption in healthcare. This is one disruption in healthcare, which is using the patient as a resource. And the patient is the most underused resource in the healthcare system today, and this is what we attempt to fix.
As a highly vulnerable, stigmatized community, people with epilepsy do not have a resource to address the practical, emotional, or social needs of living with the disease, which would enable them to exercise the control they desire to live life on their own terms. Compounding this is the fact that the healthcare system, and HCPs in particular, are focused on the medical aspects of epilepsy, with little time or interest to go beyond. But the lived experience of epilepsy is so much more than just a biomedical condition. What if we could change all this? What if we could help provide the type of emotional, social, and practical support patients so desperately need? We're here today to tell you we can. Introducing the Epilepsy Peer Navigator Program, a revolutionary, unique, patient-to-patient mentorship program designed to provide the coaching and support epilepsy patients need to engage with life on their own terms. Through this program, each patient is provided access to a professionally trained and certified peer support specialist who has first-hand experience of successfully navigating through the complexities of living with epilepsy. This reinforces the ecosystem of care by adding a new essential component to the healthcare system, the peer navigator. Peer support specialists have existed in mental health for over 15 years, and the clinical evidence of their impact is remarkable. 21.5% positive impact on medication adherence for patients who receive peer support specialists versus usual care. 30% reduction of inpatient stays. A 50% reduction in rehospitalizations. Physical component of quality of life is 2 times better for patients who receive peer support specialists versus usual care. Significant improvements on patient activation, engagement, empowerment, self-esteem, and confidence. What's more, the peer support profession is recognized by the US and is funded by insurance companies and Medicaid, thanks to a level 1B evidence-based medicine. So how does the Epilepsy Peer Navigator program work? There are 2 main components. The first part that powers the whole program is the professional training and certification of peer support specialists. UCB has partnered with selected epilepsy advocates to train them to become peer support specialists. The training itself is provided through the standard bearer of peer support training, INAPS, the International Association of Peer Supporters. Through INAPS, the selected epilepsy advocates will receive world-class training and certification as an official peer support specialist, enabling them to go beyond the anecdotal support they currently offer, with new skills and confidence to help other patients navigate living with epilepsy. This represents a whole new career path for epilepsy advocates. It's not enough, however, to just train epilepsy advocates as peer support specialists. There needs to be a way in which they connect with patients. This connection is facilitated through UCB Cares. When a patient learns about the Epilepsy Peer Navigator program through hearing an advocate speak at an event, through consultations with their HCP, or through materials provided by their pharmacist, they are encouraged to call UCB Cares. When the patient calls UCB Cares, they are asked a few important questions, which helps the UCB Cares associate determine the peer support specialist who might best fit the patient's needs. Once a best fit has been determined, UCB Cares facilitates the connection, and the peer session can be conducted following the renowned and established WRAP, the Wellness Recovery Action Plan approach. This approach empowers the patient to manage their own challenge, with the peer navigator providing coaching. Both are advised well in advance that their conversations must not touch on medication or other medical aspects. After all, this program is not meant to replace the care they already receive, but rather to complement it. The whole program is designed to gather feedback at every meaningful point to ensure that both the peer navigators and the patients benefit fully from their engagements, and so the program can continually be improved. While the rest of the pharma industry looks at more complex technological solutions to help patients navigate the complexities of this disease, the answer is perhaps much simpler. The answer is about people. People helping people. Is there anything more patient-centric? Epilepsy Peer Navigator. People helping people for better care now.
Nice. That was awesome. Do you have anything you want to add? Because you have 10 minutes. I have a question, which is like, how the heck did you make this happen? But yeah, would you like to say anything?
I'm happy to answer now to move to the
Yeah, I'd love to just hear behind the scenes how a ginormous risk-averse pharmaceutical company was able to do a peer-to-peer. I mean, yeah.
So, I mean, a few angles to that. I mean, one, it doesn't touch anything on medication and drugs, right? So this is an easy way to get okay from legal compliance, etc. You know, it has nothing to do with drugs, no claims, no promises, nothing. Actually, it's everything but the drug. They are forbidden to talk about the drug to make sure that we don't have conflict of interest. The second thing is partnering with INAPS, which is the International Association of Peer Support. It's a 501(k) organization in the US. Very well recognized. It's a professional association of peer support specialists. In the US, again, it's a profession. There are 20,000 of them in the US alone. So we tap into their training. Their training is being recognized by states, is certified. So the risk aspect is very low because they have been trained, the peer support specialists, to handle any type of question, including suicide, right? Because, okay, what if we give a wrong advice? Peer is advising the peer, not in the right way to drive, or, they can't as a PhD patient. Then, tapping into an existing program, which is recognized again, has been pretty reassuring. And the third one, I have to confess that there is a convergence of interest here, and I want to put it in the open for further conversation afterwards. I'm not shy of saying that there is a business agenda to that, right? And this should be. We all have interest from all different stakeholders, from insurance standpoint, drug, etc., but it doesn't prevent us to work together to be the best solution for patients in the system overall. The interest for us is that if you combine peer support specialist health intervention with the drug that we provide, actually we see that there is a synergistic effect. And so the outcome is better if you have 1+1 rather than one of them alone. So that's one element. The second element, which is important for us, is actually a lot of patients are locked into the system. So they are in what we call the passive market. They are not being taken care of. They don't see a neurologist anymore for the last 10, 15 years. So they stay on medications which are old and which we believe are not the right one for them. So by giving them the chance to be exposed to the system and to be inspired to take action, then most likely are they going to see a neurologist and the right care, and then they are going to be exposed to our more modern treatments that if they would not be exposed to. Right? So this is an example of converging interests, converging agendas, which actually can work really together to collaborate and connect to do, as you said yesterday, purpose-driven design. Right? So putting the human at the center is what we do.
Awesome. Thank you. Thank you. And I do want to talk more about that. But up next, we have David. And I'm sorry I took your seat, Justin.
You can sit here if you want. And there was a keynote somewhere in there. It's the purple one. There you go. Perfect.
And here's the clicker if you please.
Awesome. Thank you. Hi, everybody. I'm David Vivera. I'm the co-founder and CEO of Amino.
the first question that I think one can answer oneself to understand what Amino is doing is just asking what we, not wearing our healthcare titles and clothes, would do if we were sick, but just what we do as fathers and mothers and siblings and kids when we're sick. What tools do we use? Where do we go for information? Where do we go for support? Amino's goal is to be your partner. We founded Amino after I was previously an executive at Zillow. And Zillow is a really good example of that approach working, driving radical transparency direct to consumers to help them make informed decisions about a very high stress, high complexity event in their lives. And what we identified as one of the key barriers to that is that there's no single source of truth in healthcare. Too often what we've done is we have tried to evolve into a consumer-friendly organization, but realizing that no matter how large you are, even the largest insurance company only has one part of the healthcare system, and certainly an even smaller part of each individual consumer's perspective. So what we thought about was, in a world in which households are spent, the expenditures that people are seeing in healthcare are growing at 6 or more the size of their wallets. Healthcare is becoming the largest personal finance issue in America. It is as important or getting more important soon than that mortgage that I spent years thinking about. It's becoming even more important than a lot of the other things that you spend hours or months researching. And there is no single source of truth that you can go to make a confident decision. One of the things that I ask audiences is, what's the largest fee-for-service system in healthcare? Does anyone know? I'll give you an answer. It's the internet. Google, any health ratings website, Yelp, they are all paid for by health systems and doctors and clinics and drug companies that are trying to actually sell more volume of services. They're trying to acquire a new patient. And that is a system that is not necessarily geared toward having someone stay in network, avoid an unnecessary service, take a generic drug instead of that more expensive branded. And so every day, each one of us, when we make that natural decision about where to go get insight as to what types of care, whether we need care, what might I have, what do other people think, we're bombarded by advertising that gets us to spend more, to go out of network, and to do things that may not be in our best financial or health interests. The consumer expectations around transparency and digital tools are increasing as a result of that. You see people who do not have enough money to afford an emergency medical bill. The Federal Reserve, for example, shared that very few people could come up with even a few $100s in the case of an emergency. We did a survey that showed that 37% of people couldn't afford a $100 surprise medical bill without putting that on their credit card, without going into debt. And employers and plans are also along for this ride as well. So if healthcare is growing at 6% in the employed population total cost, and GDP is only growing at 1 to 2%, you can imagine how that's eating away profits, it's eating away investments in additional products and services, it's eating away pretty much everything. And so if you look at the data that we did with a partner called Ipsos, which is a nonpartisan polling company, obviously if people are saying that their healthcare costs have gone up, I don't think there's anything that's surprising about that. 64% of people want to figure out how to lower their medical costs, but they don't know how. And what's interesting about this is that people go to the decision that they know to make because they don't have the information to make any other decisions. And so by far and away, the most popular, sadly, way for people to control costs is to not go to the doctor at all, because that's the only decision they know how to make. Almost half of people believe that their insurance company does not give them enough information to determine their healthcare costs, and that's layered on top of the uphill battle that an insurance company has, because they do have to be the one to say no sometimes, and the one to say maybe we're working through the medical necessity of said things. So they have an awkward position that they're put in, trying as well to try to build a relationship. And so if they can't provide the information that they need, plus they've got that uphill battle, it's a real tough thing to ask of them. And so what Amino did was we started a company back in 2013. We raised a bunch of venture capital, and we spent 2 to 3 years acquiring the data necessary to answer questions like where to get care, what's it going to cost me, who is the highest quality in-network, most experienced physician to treat this, and can I book an appointment with them right now? So we have a daily stream of medical claims affecting over 220 million patients. It allows us to see inside the doctor's offices and clinics and imaging centers and urgent care centers all around the country. It's about 950,000 total facilities and practicing doctors. The data is 48 hours old, so it's very, very recent. And it represents about $1.8 trillion of health spend. And what we do very differently is we take that product, we create an independent, data-driven, unbiased resource for consumers, and then we meet them where they are. Each of us, when we get sick, we Google. There's 5 billion searches a month on Google for health-related topics. It's the largest category of curiosity on Google every month. And that's that market that's dominated primarily by drug advertising, out-of-network clinics, and so forth, which is obviously driving up further health spending. And so what Amino is trying to do is create fee for value on the internet. So we not only have amino.com, where, for example, last month we had over 50,000 or so just new pregnancies searched for on Amino. We support over 1,000 different topics. But we also syndicate all of our resources so that if someone were Googling and thinking about hepatitis C because they were newly diagnosed, we have partnerships with things like the American Liver Foundation or with Healthline or with the National Stroke Association and so forth. We partner with employers and plans. That's our business model. And so what we do is we think of our role as a company is building that authentic relationship and then selling an upgraded product called Amino Plus, which further drives people toward the higher value healthcare decision. It's almost the same, I would say it's the same thing as every other industry, in which if you are a supplier of a service, in no other industry are you the sole communicator of how to buy that service. If you sell Coca-Cola, you do not run a talent show. You sponsor American Idol. If you are a real estate agent, you are not the dominant place that people go to for health or for real estate information. You go and you sponsor everything from Zillow to bus benches. And so our approach is to build the independent marketplace, if you will, for consumers, and then allow folks who take risk, employers, plans, to be able to communicate to that member who's already using our product and help them land at the exact right place for their care, if there is a place to get care for that right now. So what have we learned? One is that awareness in healthcare with the consumer drives success. Though 5 billion searches happen every month on Google for healthcare, health is not one of those things that, as we all agree, people think about every day, unless they're in a very unique situation. And so one of the important things that you need to do in order to create a brand is to think about how do you drive awareness. So some of the things that we do as a company are we look at the content that gets created around our product. With a daily stream of data, Amino has commented on flu trends and the opioid epidemic and the costs of essential health services for consumers if the American Health Care Act, as described, is passed. And that allows us to continue the conversation about health finance, health care, physicians, quality, according to Amino. And so we work with leading media organizations. We were just in USA Today yesterday on the opioid epidemic, et cetera. But we also, as I said, make our product available over the web. We make our product available as much as possible. The second thing is that transparency in healthcare, our view, has to be a commerce-like experience. So one of the things that we do very differently is we give someone an action that has this cathartic effect that allows them to feel like they moved forward in their healthcare decision. So instead of just publishing a how-to guide or ranking physicians, we actually put a book appointment button on every doctor, hospital, and imaging center that's on Amino. And that allows each consumer to be able to register, to book an appointment, and to make a decision. And on the flip side, it allows us to communicate with our payers and with our employers, knowing where their people are going and how effective is our product in driving people toward the most optimal corners of the network. And that's what we do as a business. Next thing I would recommend is just know the job you're trying to do. So in real estate, we had different types of users, from speculators to first-time home buyers. And our perspective in building Amino was that every single person in healthcare is a first-time buyer. So 1 in 5, 1 in 6 people can actually describe the total costs of their care if they had both the plan design and the bill. And Amino's built-in out-of-pocket cost calculators and so forth connected to their deductibles that actually does the math, incorporates a glossary, gives them a word problem and a video, because there's just nothing you can assume about a consumer in healthcare. And then the last thing I'll share with you is just another thing that we learned that really drives the fundamental strategy of the product, is that consumers, that first question I asked you, where do you get your information about healthcare? Well, more people ask a friend or family about where to get care than rely on their doctor, and that's the second category. So the first category is going to a friend or family. And so a question was asked earlier about what do you measure in order to understand the success of your product. We measure religiously our Net Promoter Score, because if we've broken down the barriers of where this information can be so that everyone at the Thanksgiving table can communicate, hey, Aunt Joan, where did you get your hip done? My husband needs to also get it done. Instead of Aunt Joan saying, oh, I went to this person, she's the doctor for the local sports team, she'd say, go to Amino. And a big way that we try to measure the effect of actually being present in that conversation is measuring Net Promoter Score. And so that's all for me. What I would recommend you do is just go to amino.com. One of the nice things about our product is everyone in this room and all of your family members can use it for free. Thanks.
Thanks so much, David. Julie is up next. We have a chair for you. And by the way, I realized I was selfish during the last panel and I didn't give you all a chance to ask these people questions. So I'm definitely going to do that this time. Maybe. I mean, no, I will. I'm going
to take this off. I guess it's wired in. Hi, everyone. I'm Julie. I'm the Chief Product Officer and co-founder of Kairos. And we are in the business of helping the health system solve what we've coined the patient access paradox. This is the paradox by which we as patients are told to wait weeks, if not months, to get a doctor's appointment. And one would assume that that's because every provider is booked out solid, that there really is no capacity in the system. But as we work with our customers and actually do the measurement on the supply side, we find that capacity utilization is generally very low, far below the available capacity in the system. We find that even the leading health systems in the country are operating at about 60 to 80% capacity. And when we say capacity underutilization, we mean no use of capacity, so literally empty slots that go unused. We mean misuse of supply, so you getting sent to the wrong provider the first time, which happens anywhere between 25 to 40% of the time with a first referral. And we also mean overutilization of supply, meaning you should, if you have a headache, you shouldn't be sent to a neurosurgeon. You should be probably sent to a primary care provider or a lower acuity provider. And so we think about all those different types of mismatch between supply and demand. And when supply doesn't get matched to demand in the right way, all of the negative outcomes that you see on the bottom of the screen are what occur. We have health systems that are losing growth opportunity. You have referral leakage. David alluded to the fact that in-network care is obviously a critical part of controlling healthcare costs in this country. And then underutilized providers, again, just the mere fact that we don't really have a physician shortage in this country, we believe there is a significant amount of untapped capacity out there. And the way that we do this is through a platform that really focuses on optimizing the supply side of provider organizations. I think what's interesting about my colleagues on this panel is that many of them focus on the demand side of the equation. How do we optimize the patient experience and the patient's ability to identify who the right providers are? We focus on then optimizing the supply side of that equation. How do you understand what those providers do? So we have a full taxonomy. The Kairos Clinical Library there in the middle of the screen is is a novel taxonomy, a vocabulary for describing the 15,000 diagnoses, procedures, symptoms, etc., in both lay terms and clinical terms that map the expression of a clinical need to who the most appropriate provider is to serve that need. We also aggregate appointment inventory from across multiple scheduling systems. There is no single provider organization in the country that operates on just a single scheduling platform, and so we do all the heavy lifting of wiring into those systems, pulling out the live appointment inventory, and normalizing that data so that it makes sense to a single end user who's trying to do the booking of the appointments. And I specifically use the word provider, and our platform is called Provider Match, not Doctor Match, because we do think about not just physicians, but really any clinician or any service provider in the network. So whether it's nurse practitioners, whether it's chiropractors, whether it's an urgent care clinic versus the actual acute care facility, all of those are fair game to be managed within our system. So on the back end of our platform, we're really doing that creation of a digital inventory of all the providers in a given network. On the front end, we then have a series of workflow applications that are designed to actually do the matching. How do you, when you have a patient in front of you, how do you make sure that that patient is getting not only matched to the right provider, but also being able to be booked with an appointment with that provider? So our mantra is sort of your ability to find the right doctor is only as good as your ability to book an appointment with that provider. And so we have three major workflow solutions that are deployed today. One is, I'll actually start in the middle. One is a provider match for consumers application. It's essentially a white label find a doc, an online scheduling tool that a health system can use on their website or their mobile apps to drive the consumer facing experience. I start there because it's actually from an overall volume, transaction volume perspective, the fastest growing, but by far the smallest in terms of transaction volume across our platform. The vast majority of appointments today are still booked through some kind of offline mechanism, whether it's through a phone call, a call center, or a doc-to-doc referral, or I'm being discharged from the emergency room and I need to get matched to a provider who's based in my community. So the vast majority of transaction volume actually flows through our two other products, one which is a call center solution called Provider Match for Access Centers. It is an application that call center agents, call center schedulers are using to essentially ensure that you're able to be booked with an appointment in a single call. Healthcare, when compared to other industries, is terrible when it comes to closing the deal, so to speak, in one call. The average number of transfers that a patient has to go through to book an appointment is over 3, and 70% of calls into a healthcare call center have to get transferred to someone else to be able to book the appointment. So we're trying to reduce that down to a single call, and then also streamline the experience for that call center agent to make sure they have all the information they need to book that appointment. We have a network referral solution, which is used at the point of service. So how many of you have, when your primary care doctor says you have to go see a cardiologist or you need some other kind of referral, are handed a piece of paper with a phone number on it and told to go figure it out yourself. We're trying to solve that problem of basically making sure that you're getting matched at the point of service to the right provider and booked with an appointment before you leave so that you are confident that you're actually going to get the care that you need. So those are the solutions that we have on the market today. Our fiduciary, our customer, is large provider organizations. So we work with large health systems across the country. We have roughly about 90,000 providers on our platform today for whom we have deep, rich data. So we're, again, managing that digital inventory piece and then also facilitating the booking of appointments into those schedules for these customers. And speaking of measurement, we think a lot about, I would say, two major things. One is utility, so making sure that our product is actually helping the people do their job better and booking those appointments. And then also ROI, what is the actual return on investment that we're delivering to our health systems based on that utility. So some stats here. We have shown multiple times over that we are literally increasing the utilization of provider capacity. When I talk about that 60% utilization stat, we're able to increase that very significantly for the organizations that we're working with. We're able to eliminate misdirected referrals, so making sure that the provider is getting sent to the right provider the first time instead of being sent elsewhere and having to be re-referred and therefore wasting a slot, so to speak. And then also improving demand conversion, going back to that stat around, you need 3 calls to actually book the appointment. We're trying to increase that to as close to 100% as possible with that initial encounter that the patient has with the health system. Each of these stats results in tens of millions of dollars of ROI to our customers that we're able to take credit for at the end of every year. And that's it.
Awesome. I'll take your place here. So I have a couple of questions for you guys, and then I'll turn it over to the audience. But the name of this session is Navigating the Health System. And, as Robin touched on and Greg as well from UCB, in order to navigate the health system, part of it is the having the right information, right, and the right tools to get at the right information. The other part is awareness and empowerment. So just a quick story to help frame my question. My daughter had an allergic reaction after going to McDonald's. Interesting. And her lips swelled up a little bit, and she had a little, was a little wheezy, but it's not like, she was not able to breathe or anything like that. And of course, knowing what I know about the health system, I'm like, if I take her to the ER, that's going to be way more expensive than if we go to like the urgent care center, right? And so we went to the urgent care center, and they said, "Are you having trouble breathing?" And she was kind of wheezy before, but I had given her Benadryl, and she was feeling better. But she said, "Yeah, before a little bit." And they're like, "If you're having trouble breathing, we need to get you on an ambulance as soon as possible to the ER." And I'm looking like, she's fine, like but feeling like a negligent parent, like we should pull out all the stops. Like what if she, but I'm like, we're going to drive to the ER now. Thanks. But I don't even remember if we went to the ER. I might have just given her more Benadryl and she was fine. But the point is, like, I was having common sense, but like common sense is risky, right? Because we know all the things that can go wrong. So I think we were talking about, finding doctors and treatments in kind of a chronic situation. Acute care is a little bit more difficult, where you might be recommending treatment that's recommended because there's a 1 in 1,000 chance that something might happen, and your loved one, yourself, might be that 1 in 1,000. And so, I get that, but how to empower the consumer, in real time to get information and make decisions, especially when it's kind of going against what the system might be recommending. So just wondering if you have any thoughts on that.
I was going to say one thing just on the kind of a structural challenge, I think, with the industry as it is today is exactly what you just described. You have kind of EDs, which are your traditional place for getting acute care, where there is a specific scope of services that are provided, but at a very, very high cost. And then you've got your urgent care clinics and retail clinics that are disrupting that space, but they today have a very, very small scope of services, largely because a lot of them are staffed by non-physicians, and the reimbursement landscape is evolving. So I think that's unfortunately one of the examples of sort of, just where we are as an industry and the need to actually wait for some of the regulations to kind of catch up with where consumer demand is today. I would say at the same time, however, many of those gaps, so where you have those types of gaps, the types of tools that many of the folks here represent, and just general information sources about things that are understood well enough that a consumer should be able to kind of do their own self-service navigation of what options there are. I do think that there is a rise in those types of sources as well. But not to be sort of pessimistic about it, but I think the reality of part of where the system is today, from a regulatory, all the barriers that were described in the last panel, regulation, scope for practice legislation on a state-by-state basis, understanding all the scope of services, that is a reality of the system today. So I do believe we are in a transition period where the pendulum is sort of swinging, one into the other.
I just think, healthcare.
Healthcare is, at its core, people are going to think this is controversial, it is a consumer-driven business. It just so happens now that the deductibles are so large that it's actually a direct line between the consumer and the provider. I'll give you an example. Urgent care clinics are sprouting up like crazy only over the last 5 years. And the reason is because deductibles are so high now that people would rather just basically have a high deductible plan and then go to the doctor only as necessary, which is why young people under the age of 35, dominant use of the healthcare system is not to have a primary care physician at all, and to think of urgent care as your sort of first point of care in the healthcare system. And one of the things that I think is interesting is that, I do think that this is a transition of consumerism that's going to last many, many years. So if you think of a behavior pattern that's been trained over many generations, really, of going into an all-you-can-eat healthcare system feeling like you're just there to get treated and the financial aspects don't matter. We have to train people how to think about these things, and that's just not something that happens overnight. In fact, you see it happen often where a journalist writes about how just messed up it is that it costs this much to have a baby, or I can't find out how much it cost me to get an MRI. And almost always that comes from the fact that that journalist for the first time really screwed up. But until they screwed up, they had no idea the types of landmines that they were going to run into. And I think it just takes a while for all of us either to screw up once, or it just takes a while for enough social behavior, convenience, and access to information makes it more likely that people are going to adjust. And so one of the things that Bill Gates says is that you kind of overestimate the effect of technology in the short run, and you really underestimate the effect of these shifts in the long run. I think this is a 10-year shift, but I believe that this is consumer directed. If you just look at urgent care as an example, one of the things to observe about urgent care is just another case where fee-for-service is really kind of dominating your experience. You see urgent cares that are constantly being affiliated with or acquired by large hospital systems as essentially feeders into a more expensive setting of care. And so most people don't know that, and they just think they're going to an urgent care, but they actually absolutely are incentives that get you to spend more even inside of urgent care.
Yeah, so let's go to questions. Matthew is raising his hand.
So, first, Dave, you've got to stop giving Bill Gates credit for that. It's Roy Amara. This is a quote from this. This is a question for the whole panel. You guys know I'm obsessed with this topic, which is why I'm sitting here. Actually, between you lost over to the right, you know that. So, all of you are data plays. All you're trying to figure out the most effective way of getting now, what you just said just about collective, the most effective way of getting a patient to the right place. We know it's a massive problem in the system. You're all coming in from different angles. On stage this morning, Robin talked about health coaching and sort of health advocacy as a growth industry. None of you explicitly say that's what you do, although Justin, with your new announcement, your new product collective might be getting closer to that. Do you think that the end state of your current business is something that happens separately? Do you stay with separate organizations? Or do you think there is a layer that takes data from all of you and somehow integrates that and becomes the, I don't know if it's the Alexa or whatever the hell it is, but the thing that actually helps do that, it's patient matching with preference, with benefits, with doctors, I don't know what it is. But where does this end up in 5 years? Who's doing this role? Where do you guys really fit into that? It's a complicated question, but Julie, you're a very clever SingStar.
Yeah, I strongly believe that there will be a convergence over time, but I would specify what kind of data we all sort of focus on and compete on. So today, I think that the industry is so broken on even the most commodity data that you can actually build a business aggregating very, very commodity information, and that is a valuable thing that the industry will pay for today. And that, I think all of us represent some version of that. You know, we're focused on basic demographic information, locations of providers, and when they have appointments, which, you know, at the surface seems very, very basic and trivial, but when you start digging into how that data is stored today and all the semantics of different scheduling systems and the lack of standards across, you know, for providers, even practice by practice, that's a massively hard problem to solve today because there is just, you know, lack of interoperability. So I think in the short term, that's where many of our businesses are focused. I do believe, however, that there is a convergence. I mean, for one, we partner with a lot of companies like Amino and syndicate our data to broader marketplaces that then have additional value-added components and get exposed to consumers in different ways. So that is already happening to some extent. I then think that the pressure is on us as businesses to then really create proprietary and novel data streams on top of that. I think we're just scratching the surface of it. You know, Justin alluded to some of that, but that's also a lot of what we think about is what are those proprietary metrics that get to, you know, the quality of capacity and different ways to predict, you know, how do you optimize your templates such that you can meet the demand that's coming into your system, things of that sort. So today I think that many of us are trying to solve some pretty basic problems just because of the state of the industry.
Yeah, I think there is an element of data integration, but there is, for me, more importantly, an aspect of data verticality in a way. So what do you do with those data? And I think to the future you describe, I think it's the data and the use of it. I can see a Verily or a Watson taking an important role in healthcare because they are integrated integrators of data, they make sense of it, and now with that they can develop, in our case, new drugs, right? They can be more focused on which subpopulation, which mode of action, etc. So if they make a smart use of data, they can go all the way to also replace insurance companies and say, hey, there is a better plan for you. And they can even, like Watson does, develop a new plan, right? I mean, Watson now is creative. It takes recipes from the best chefs in the world or the best music in the world, and now it creates a new symphony or a new recipe. I see that in healthcare. If there is a Watson being smart, it will use this data and say, you know what, that's the amino of tomorrow. This is, the Aetna or Humana or whatever of tomorrow, because it will make sense in a blank sheet of paper, not 50 years of history, just the best of the best. This is for me the kind of scary future I see in healthcare. I don't know if it answers your question.
Yeah, and I think what you were getting at too, Matthew, is that data is great, but data gets us to the point where we make a decision and we need to explain those decisions to others. So it's almost like there needs to be a level of kind of education baked into your solutions that helps people have those tough discussions with doctors. I mean, Robin can get up on stage and be like, I fired Stanford, but not everybody has that kind of personality and can have discussions that say, no, I decline the x-ray, I decline the ambulance ride, I want to go here instead of there, I want to get a second opinion. There's psychology involved with that, I think, that we need to coach people on, in addition to providing them good data.
Yeah, so I would say from our point of view, a collective, we see an important convergence of data in some ways, but actually to empower what we think is, sort of the negative way to say it is like fragmentation, but we actually see it as a positive innovation of all these really interesting solutions that are popping up that haven't been pulled together in a way that makes sense. And so what we think is a convergence that helps everyone win is creating some common rails of certain types of data for, claims, payments, the basics that, frankly, all of the partners that we work with don't need to reinvent the wheel on. We just need a common way to talk to each other. And then to actually empower as close a connection as possible between that member and that solution. And then, then actually to get the data back out and see on the metrics that matter, which solutions are working and enable everyone to iterate faster. So are you actually impacting the costs, the quality, or the experience for people? And to pull that data together in a way that employers or payers, anybody who's trying to assess the potential impact of a different program, solution, something to manage diabetes, telemedicine, musculoskeletal, whatever it is they're trying to figure out, what's working, and make those decisions instead of wasting time actually just trying to plug wires together.
Yeah. We have time for one more quick question.
This idea of getting the right patient in front of the right provider. On the provider side, there's a clinical thing, that this person's good at doing knee replacements. Are any of you doing things more qualitative, meaning how much parking do they have? What's the traffic at that time? Because I know my own experience, there's a good chance that one or both of my kids may be with me. So if there's not a play area for them, it's going to make our collective experience horrible, regardless of what the outcome is. And certainly, you want to go where you're going to be successful clinically, but are you doing anything to incorporate those other things in terms of the size of the wait room, how long you're waiting, parking, traffic, those types of things into the right provider?
And I want to add a question into your data set question. The guy who wrote the book Unaccountable Care, I'm spacing on his name, he's like medical CEO of Johns Hopkins, said that some spinal surgeons will, I think he said the majority of spinal surgeons he interviewed said that they recommended spinal surgery without even trying physical therapy first, and that they said a third of the surgeries they recommend probably aren't necessary, and there's quality measures around that. So I wonder about introduction of that data as well.
I think it's all of these things, right? I mean, but it depends on what you're searching for, right? So if you are searching for a knee replacement, a lot of people want to see the outcomes and want to see whether they're in network and what the total cost of those things are going to be, because you can go this Tuesday, you can go 2 Tuesdays from today, you can go next month, but if you have the wrong knee replacement and you have a revision, that's a real problem. And part of our job is to educate people that those metrics do exist, right? So we do have knee revision rates and experience specifically on knees for doctors and all those sorts of things. Having said that, to kind of answer both of your questions, our point is just to help the consumer. Data is just one part of that. And so, for example, we have reviews on our site. We have things about this sort of consumer experience about those doctors. When we come out with some things in urgent care and ER, we are going to have absolutely wait times and other things like that built right into Amino, because at the end of the day, our view is that the person who, or I would say the entity, the company that wins this transition is whoever builds an authentic relationship with as many consumers as possible. The employers just care about engagement to drive savings. The providers just want to, get patients in full capacity. And so we're going to do whatever it takes to make sure that a consumer feels like they're informed and they have an authentic kind of trusted relationship. And for an ER or urgent care visit, it may be they're open, they're available, they have imaging on site because I think I broke my arm, that sort of thing.
I was just going to put in a plug for that was Marty Macri who wrote that book. He's actually on our clinical advisory board. It's a great book. We give it to all of our employees when they get onboarded to Kairos because it's actually a lot of the thesis behind the business was around exactly that. I would say absolutely yes. Our customers do actually use our platform to capture qualitative data. That part of why that didn't exist before is they literally didn't have data systems to store it. If you think about where the massive amounts of dollars have been spent in health IT for the last decade or so, it's all EMR, and so there was a huge emphasis on collection of clinical information about patients, but a severe lack and underinvestment in all the other types of information that is necessary to do this the right way. So we are seeing that trend, and customers are starting to think a lot more about the qualitative patient experience aspects of things. I would say that in the last 2 quarters, the percentage of budgets for our solution that shifted from operations to patient experience is very, very significant. So you are starting to see healthcare organizations allocate explicit money in these kind of things.
I know a design firm that can help you on the experiential side of things. Just soft plug there. Soft. Thank you to all our panelists. This was wonderful. Thank you so much. Let's eat.